today's 16th CME.
Yes, sir.
16th CME of Bihar Jharkhand Society of Anesthesiologists. It's indeed a pleasure for me to be with you. I'm very happy that I'm associated with this, and it's wonderful that the postgraduates are presenting the cases, and there are two examiners for this, and there is an expert, Dr. Rakesh. I mean, it's wonderful. The topic chosen is also wonderful about thyroid, and it's very useful for the postgraduates who are going for the examinations. And I do not want to take much time in between you and the case presentation. So I request Dr. D.K. Singh to do the proceedings. Thank you very much.
Thank you, sir. Thank you very much, our President-elect ISA National. Thank you, sir. And I would like to, Dr. Sarad, our Secretary of the Bihar Jharkhand State.
Yes, sir. Sir. Yes, sir.
Please go ahead and start the procedure function.
Hello.
हाँ, आप start कीजिए.
Yes, sir.
Dr. Garg has joined. Sharad, you can welcome.
Dr. Rakesh Garg has joined. Welcome, Dr. Rakesh.
Dr. Rakesh, welcome.
Yes, sir. Yes, I can see, sir. I can see. I request.
Sir, good evening, sir. Good evening. Thank you so much.
Good evening, sir. Good evening.
Sir.
So it's almost 7. So we were going to start exactly as we decided. We will start on time. So welcome everyone. First of all, I would like to welcome our President-elect ISA National, Dr. Vimeshwar Muparao. Sir, grand welcome to BJSA. It is really our honor to have you with us today. This, as you know, sir, this is the 16th CME in a row. BJSA has started this thing when the first COVID wave hit us, and since then we decided that we should do something interesting for our members, especially for the PG students. So on the monthly basis, we are conducting the CME and the PG session. This is the third PG session. Although we were doing the CME with the faculty, with off and on involvement of the postgraduate students, but now this is the third CME where only the PG are presenting the cases in front of our internal experts, and sometimes we also invite the external expert. Today we have external expert. I will not say the external, I will say the expert. Dr. Rakesh sir is with us. He will present the detail about the thyroid and anesthesia. So without wasting any time, I would like to invite our internal Dr. Ashok Jardanson and Ajit Gupta sir to start the proceeding. And today the presenter, the student is Dr. Sagar Rai. He is a second year student of the Kishanganj Medical College, MGM Kishanganj Medical College. I welcome Dr. Sagar Rai. It is really very fascinating and very good moment for BGSA that students are coming to present. They're nominating themselves. Sir, I want to present. This is the best part of the CME, that the students are giving their name, himself or herself. So today we have Sagar Rai, and I now invite Dr. Jadar and Dr. Ajit Gupta to start the proceeding without any wasting time.
So good evening, respected Bhimeshwar sir and Dr. Dinesh and all my senior colleagues. Dr. Rakesh, good evening. And I would request, without wasting time, I think as Dr. Sharad has mentioned, so we go directly to Dr. Sagar Rai and requesting him to present his case of thyroid. Yeah, Dr. Sagar. So
thank you very much, sir.
Yeah.
A very good evening to our guest of honor and chief guest. I offer my humble greetings to our examiners, Dr. Ajit sir and Dr. Ashok sir, and my humble greetings to the executive committee members and today's expert. So today my topic is anesthesia concerns in thyroid surgery. And thyroid is a very well-known topic, and it has been done over and over again. So I will proceed with a case presentation, and through the case presentation, we will slowly move on to the second half of the presentation, which is about the common concerns in anesthesia. We will go through the pre-op concerns, the intra-op concerns, and the post-op concerns. At the end of the presentation, we will briefly discuss the thyroid emergencies that can come up, like thyroid crisis and myxedema coma, thyroid storm. So without further delay, I'll start. My name is Dr. Sagar Rai. I'm a second year junior resident in the Department of Anesthesiology in MG Medical College, Kishanganj. The patient we have is a 62-year-old female called Sunita, whose name has been changed to protect privacy. Throughout the presentation, her pictures have been slightly concealed to protect her identity. She comes from Thyroid Kishanganj, and her occupation is a housewife. From the best of my knowledge, Thyroid is not an iodine deficiency endemic area. So let us proceed. The patient presented to surgery OPD with a complaint of swelling on the front of the neck since 6 months. After their workup, they forwarded the patient so we can optimize him for a upcoming surgery. So as you can see in the pictures, it was a bilobe swelling extending throughout the width of the anterior part of the neck. So this is the history of presenting illness. I'll be brief and quick, and I'll focus on the positive findings as much as I can. Patient was apparently asymptomatic 6 months back when she noticed a swelling on the anterior part of the neck. The swelling developed spontaneously and was gradually progressive in size. It was paleness. It was not associated with any skin changes. Patient was also complaining of occasional palpitation and dizziness. There was no history of dyspnea, chest pain, dysphagia, sleep disorder, voice changes, hemoptysis, snoring, daytime drowsiness, no history of weight loss or weight gain, no loss of appetite, no predisposition towards any cold or heat intolerance. There were no mood swings, there was no depression or irritability. There was no change in sleep habits, no tremor in limbs, no muscle weakness. This was as per the history of the patient. No vision changes, diplopia, pain or burning in the eyes, no constipation or diarrhea, no history of hair loss. No swelling noticed in any other part of the body. The patient menstrual history said that she had been menopausal for the past 25 years. And there was no history of any postmenopausal bleeding. In the past history, patient was incidentally diagnosed with hypertension on admission to the hospital. And for that, she was started on the tablets atenolol 25 mg OD. There was no other significant history of past medical or surgical interventions. Obstetric history, patient underwent 2 NVDs 30 years and 32 years ago. In her personal history, she was on a vegetarian diet. There was no tobacco or alcohol consumption history and no known allergies. In terms of vegetarian diet, she had no particular predisposition to any goitrogenic brassica family vegetables. Family history, no similar swelling was present in any other family member. Coming on to examination, the patient had a normal build and nutrition and normal appearance of face. Height was approximately 4 feet 10 inches and weight was 45 kg, which brings her BMI to about 20.83 kg per meter square. Her vitals were pulse 78 beats per minute with normal rate, rhythm, and volume. Her blood pressure was 130 by 82 mmHg. She was afebrile to touch. On cursory examination, no pallor, icterus, clubbing, cyanosis, cervical lymphadenopathy, or edema was visible. We move on to general examination. We started with the eyes. So eyes, lids, appearance and movement appeared normal. Von Graefe sign was negative, Geoffroy sign was negative, Stellwack sign negative, Mobius sign negative, and Dalrymple sign was negative. On examining her hand tremors, there was only normal physiological tremors. Tongue appeared normal and moist. Skin appeared normal to touch, and her extremities were warm as expected. This is a picture of the eyes of the patient. As we can see, the amount of palpebra visible, the degree of globe visible was very much normal. I could not attach a video. On looking down, there was no sign of lid lag. On sideways examination, there was no evidence of proptosis. Examination of the swelling. Upon inspection, diffused swelling was present on the anterior aspect of neck, approximately 10 to 15 centimeter. This is an estimated size just by seeing it, and 10 centimeter in height. This was extending throughout the width of the throat, more prominent on the left side. The swelling moves upwards with deglutition. There was no significant prominence of neck and thorax veins. The swelling does not move with protrusion of tongue, and there were no skin changes. Upon palpation, the swelling was uniformly soft in consistency. It had a bosselated or uneven surface on touch. It was slightly mobile. It was, to be exact, 10 centimeter by 12 centimeter in size. Lower border of the swelling was palpable. On insinuating the fingers, tracheal deviation towards right side was experienced. Walker's test was negative. Pemberton sign was negative. Carotid pulsation was palpable bilaterally. There were no pulsation or thrill palpable in the neck swelling. There was no cervical lymphadenopathy palpable. This is the Pemberton sign. We held the patient in this position for around 3 minutes, and there was no congestion on the neck or face. I have tried to add a video for this part. I have asked the patient to perform deglutition, and by keeping my thumb palpating for the isthmus and the nature of the swelling. Towards the end of the video, when the thyroid or the swelling moved up, I was able to insinuate my finger under the swelling. So going under the swelling was possible in this patient. On percussion, there was no substernal dullness. On auscultation, there was no bruit or added sound over the swelling. The measurement of the size of the swelling was 10 centimeter by 12 centimeter. The swelling had one nodule on it. The large nodule was around 2 centimeter in size. Systemic examination. Normal S1, S2 sounds were present. There was no murmur associated. Respiratory system exam, there was normal vesicular breath sound, no added sounds. There were tracheal deviation towards right side. She was conscious, alert, oriented to time, place, and person. There was no signs of anxiety or irritability. Abdomen was soft and non-tender. No palpable organomegaly was there. Musculoskeletal system, upper and lower limbs, on all joints, we could elicit 5x5 strength. Coming to airway examination, this is one of the earliest red flags that we encountered. Her mouth opening was only 2 fingers, that too not a proper 2 fingers, slightly less than 2 fingers. Inter-incisor distance was only 1.7 centimeter. Her dentition was normal. There were no loose teeth, no artificial dentures. Retrognathia was absent. Upper lip bite test was only a class 2. Thyromental distance was 8.5 centimeter. Malambati grade 4. Facial contours appeared normal. Oral cavity had no visible mass. Palate appeared normal. Neck mobility was normal, both in side-to-side direction and upwards and downwards direction. Temporomandibular joint had normal mobility. Sternomental distance was 13 centimeter. Neck circumference was 40 centimeter at the highest point of swelling. Nose and nostrils appeared normal. Ratio of height to thyromental distance was 17.29, which was again an indicator of difficult airway. Delicate test, the left and right fingers were in line. We would expect the left finger to be higher, but they came to be in line. The patient was referred to ENT department for a video laryngoscopy, and according to their report, bilateral vocal cords were equally mobile and bilateral arytenoids were equally mobile. Her blood investigations were performed. T3, T4, and TSH were within normal range, and there was no history of any kind of oral medication or any medication whatsoever for any thyroid disorder. CBC, RFP, LFT electrolytes, including calcium and bleeding profiles, were within normal limits. Her ECG was within normal limits. On imaging, it was visible that chest X-ray had a right-sided tracheal deviation, and this was also found in examination earlier on, and the findings were confirmed. On the lateral neck X-ray, there was no subglottic stenosis or any other signs of compression of the trachea. Ultrasound of the gland was performed, and it was suggestive of bilateral multinodular colloid goiter. USG whole abdomen was also performed, and there was an incidental finding of fibroid. The 2D echo had a 60% ejection fraction and had a normal study. So the diagnosis that was made was a multinodular colloid goiter, and the plan was total thyroidectomy. So in a total thyroidectomy, according to literature, the possible options for anesthesia is general endotracheal anesthesia, which is a very popular option. General anesthesia with alternative airway.
Dr. Sagar, I would request you to please stop here and give the internal Dr. Ajit Gupta and Dr. Ashok Jadal will take you further. Okay, sir?
Yeah. Dr. Sagar, we will ask you. Now you have presented, so you leave our rest of the discussion for the question answers. You are well prepared, so there won't be any issue. And Dr. Sharad, I think we should proceed with the Dr. Rakesh lectures.
Hello. Actually, sir, he has to give the the main aim is to ask the question also and how to go ahead in the final exam. So I think sir, we should finish this first, then we will take the request that Dr. Rakesh Garg to start. What do you say?
Yeah, as you wish.
So let's finish this session, sir.
Yeah.
So Dr. Ajit Gupta, sir, have you joined, sir? There was some technical issue with him. I think there is some network issue with Dr. Ajit Gupta, sir. So I request Dr. Jadal to please continue.
Okay. Yeah, Sagar, so but a very good presentation. I would like to ask certain questions from you. You said that swelling was for 6 months, isn't
Yes,
it?
sir. Yes, sir.
So if the swelling is for, say, about a few years of the duration, does it matter? And if it's so, what could be the concern?
Sir, a swelling of longer duration had more time in contact with the trachea. So we would suspect tracheomalacia or laryngomalacia. And a long-standing swelling, if by any chance, if it was malignant or it was growing in any direction, there was a high suspicion of the swelling extending into the retrosternal region or the swelling infiltrating into the trachea. So any swelling,
by duration, you suspect the swelling is going toward the retrosternal area just by merely duration?
sir, by duration, we can suspect that there can be higher chances of tracheomalacia or laryngomalacia, especially if the swelling has been there for more than 5 years.
Yeah. So you said it is the thyroid swelling. You just narrate the total diagnosis at the end. What is the total diagnosis of your case?
Sir, my diagnosis is elderly female presenting with a neck swelling diagnosed to be multinodular thyroid goiter with no other comorbidity, with one comorbidity of hypertension coexisting with thyroid disease.
Would you don't like to mention about the treatment? What surgery she is planned for?
So yes, planned for total thyroidectomy.
So that has to be included in your diagnosis.
Okay, sorry.
I would like to know what are the differential diagnoses of this swelling, neck swelling.
So a swelling presenting in that part of the neck could have been a large thyroglossal cyst, and it could have swelling. It could have been a parotid gland swelling, but it could have been a bit.
How will you differentiate between this, as you said, thyroglossal cyst? You just keep telling us the differential feature also, because we have to find out some test or some something in the difference. Yeah.
Sir, a thyroglossal cyst, upon protruding of the tongue, it would move upwards.
So it was not moving.
No, sir.
Else?
Other
diagnosis? Other differential?
other diagnosis could be a laryngocele, a large laryngocele presenting in exact same area. We would expect some sort of voice changes if a laryngocele is there, and there are higher chances of a breathing difficulty. And though not always present, some sort of dysphagia could be present.
Okay.
Dr. Jadhav, Jadhav sir, as Dr. Ajit Gupta sir is having some issue, can I request Dr. Rakesh Garg with your permission to join?
It will be a good, very good decision, Dr. Sharath. Let him come in so he will know exactly that.
Exactly. Yes, sir. So Dr. Rakesh Garg sir.
Lecture also.
Yes,
Dr.
sure.
Rakesh,
Yeah,
can you join, sir?
Yeah, I have joined, sir. I'm ready. Just please allow me to share the screen.
No, sir. What I'm saying, sir, you join as an examiner, sir. Then you will present. That will also give some idea to students how which type of question. Okay, sir.
Yeah, absolutely. I will just follow Dr.
Yes, please.
You will know that what exactly a student is deficient, and then you can cover up in your lecture that deficiency.
Perfect. Right. So I think he has presented a good case, and you started rightly. So there has to be some differentiation regarding the benign versus malignant cases that you find out. So how will you confirm that this is a origin of benign thyroid swelling or it's a malignant thyroid swelling?
Okay, sir. Sir, the swelling has been there for 6 months and has grown only slightly in size. A malignant swelling would show a rapid progression in size, whereas a benign swelling will have a very slow progression in size. And in a malignant swelling, there can be other features which are generally common to any malignant disease, like severe weight loss, change in appetite. There can also be, if it's a secretory tumor along with malignancy, then it will show features of hyperthyroidism, depending on the the features of thyrotoxicosis.
So at this point, if you give this answer that secretory tumors, the next question as examiner would be, can you name what type of secretion or what type of secretory tumors are seen in malignancy? So the type of malignancy and which are the secretory tumors and which are the known secretory tumors, which is the commoner one, and what is the thyroid status in patients with commoner thyroid malignancy?
Okay, sir. For example, if we have something like follicular adenoma of the thyroid or medullary carcinoma of the thyroid or anaplastic carcinoma of the thyroid, these are the three more common categories of thyroid carcinoma. In follicular adenoma, we can have a secretory follicular tumor, which would present with a hyperthyroid status. Medullary carcinoma may present with hyper or hypothyroid status, and anaplastic carcinoma does not have any specific predisposition to either side. Again, could present as either of these conditions.
So, sir, Dr. Sagar, how would you differentiate clinically or by history that it is a hyperthyroid state or the hypothyroid state? A few salient features would you like to ask?
Okay, sir. In a hyperthyroid state, we would expect features of hypermetabolism. So, patient would have a jittery and anxiety sort of aptitude. There would have been a history of weight loss, heat intolerance, altered appetite, sometimes diarrhea, sometimes constipation, with diarrhea more predominant. The patient, if has gone towards thyroid ophthalmopathy, would show ocular features like proptosis and exophthalmos. The patient can have tremors in the limbs. It can be skin changes like dermopathy. Then there can be sleep disorders with excessive arousal at night. And these are some of the features which can be present in thyrotoxicosis. And in hypothyroid state, there would be decreased metabolism. So patient would have cold intolerance, constipation, weight gain. Weight gain is subjective because sometimes there can be concomitant decreased appetite as well. So that's varies from patient to patient. There can be decreased mentation, decreased arousal, excessive sleepiness. And there can also be episodes of depression in the patient. There can be hair fall, particularly towards the lateral part of the eyebrows called madarosis. So these are some of the features of hypothyroidism. So.
Would you like to know other endocrinal disorders also to assess the patients? If you are assessing a thyroid tumor, would you like to know about the other endocrinal disorder? And if it is, then what it is?
Sir, thyroid sometimes presents as a part of multiple endocrine neoplasia. So if it's a MEN2A condition, it can present with parathyroid tumor. So we would ask for any history of
only parathyroid tumors or something else? As you are talking about the men, what are the types if you narrate them?
Sir, there is MEN2A, MEN2B, and MEN1. Sir, MEN2A presents with mostly thyroid carcinoma with parathyroid involvement. MEN2B is presenting with again thyroid involvement, and MEN1 presents with insulinoma, thyroid swellings, pancreatic swellings, and GI swellings. Sir. So if we are suspecting insulinoma, we would want to know any prior history of loss of consciousness due to hypoglycemia or any prior sugar derangement history, any treatment she's taking for these things, and any rapid weight loss, excessive urination history is there. If we are suspecting a coexistence with parathyroid tumor, we would want to know any derangement of calcium. So any bone diseases if she has experiences frequent twitching of muscles or spasms in the muscles, this kind of history, sir.
Do you know what chromosomal aberration causes all these men syndromes?
I'm sorry, sir. I do not remember the chromosomal aberration.
Okay, Dr. Rakesh.
Yeah, Dr. Sagar, you mentioned about various clinical symptoms which can happen with thyroid disorders. Can you just define me that which are the obstructive symptoms that can be seen with thyroid? Which are the structures which are obstructed, and what will you look for in your clinical examination, including symptoms and signs? Okay, sir.
So reasonably large thyroid swelling can cause obstructive symptoms in trachea, sometimes in esophagus, and in the veins, large veins of the upper extremity. So to rule out tracheal involvement.
Which is the commonest large vein? You said large vein. Which is the commonest that will be of clinical concern to us? Because small vessels is okay, because in the neck there are a lot of collaterals for venous drainage. So what about which vein which will have a clinical implication for us and we should be looking for?
So the deep jugular vein.
Repeat it.
The deep jugular vein, sir.
External jugular vein, you want to say?
Yes, sir.
But external jugular vein has a lot of collaterals. If you see these patients over the thyroid mass, you will say a very much dilated superficial veins. So EJV will just diversify, and the venous drainage will be almost issues, will not be a big issue. Any other vein that will be a big concern?
Sir, if it is extends into the retrosternal region, and it can affect the subclavian vein. So it will affect the venous drainage from the upper limbs, causing congestion in the limbs.
Subclavian vein, you are doing some Pemberton sign, isn't it?
Yes, sir. The Pemberton sign shows the veins on the anterior part of the neck, sir. And the return coming from the head, sir.
So probably the superior vena cava is one vein that will be of issue. Subclavian vein is very deeply situated. Unless it is infiltrated into the pleura, going into the intrathoracic region, which is primarily in the mediastinum. So it will not be going into that area. Then it becomes an extensive tumor. So you mentioned about airway, you mentioned about esophagus, you mentioned about the vein. Any other structures can you identify for me, which will be of a concern for us, and which are a concern, in fact?
Sir, compression of sympathetic tract could lead to Horner syndrome.
Very good. What else? Another important structure which you try to assess preoperatively, even after the surgery.
Sir, the carotid sheath we try to palpate and assess for the Berry sign.
It's okay. Carotid sheath is
actually preoperatively you assess by involving somebody else or an expert from other field.
Okay, sir. So the movement of the vocal cords, and
yes.
so if there is already an involvement of the laryngeal nerve, then there could already be voice changes.
Which nerve? Which nerve?
Recurrent laryngeal nerve.
Good. So you should remember that these are the 5 structures that you should look for, which may have compressive symptoms, right? And you should look for the signs. You know that airway obstruction. If so, what will be the difference in the airway obstruction with regards to benign versus malignant thyroid swelling? Because this will be of a concern during securing the airway, and this will also be a concern during extubation.
Sir, a benign swelling would overlie the airway, and there can be some level of stridor if the compression is very a high pressure compression. But apart from that, it is unlikely to cause much symptom. A long-standing one can cause weakness in the tracts, so tracheomalacia or laryngomalacia can occur. But a malignant swelling can infiltrate into the trachea, so symptoms like hemoptysis and cough could be presenting symptoms. Apart from that, there can be infiltration into the laryngeal inlet, sir. So at the time of intubation, the visualization will be affected, and intubation itself will become much more difficult in this patient.
Right. So I think this is an important point. So when you said it's a long-standing swelling and the patient have some airway obstruction on supine position, so you have to plan that this patient probably will require airway management in an head-up position or maybe a lateral position, right? And yes. Is there any maneuver that you can do for these patients that can relieve their airway obstruction when you are managing for the induction for these patients? A difference between benign and malignant?
Sir, from what I know, we need an assistant who can, at the time of induction, with his hand raise the tumor slightly, so that due to muscle relaxation, there is not excessive compression.
So that's the difference. When you say it's a long-standing benign goitrous mass, tracheomalacia, you can lift the tumor mass or the thyroid swelling up, and probably it may relieve the obstruction. It's not definite. But in case if it's a malignant one, lifting it up will not matter because, as you said, it is infiltrated. So your plan of action for these patients would be differing in these 2 aspects. And as Sir only mentioned that you usually should get an ENT opinion for doing an indirect laryngoscopy to look for the vocal cord functions, because post-operatively when you extubate, if there's a paralysis of the nerves, then probably your management of extubation may differ at some times. It may be paralysis or it may be a total paralysis if the tumor is being infiltrated by the thyroid mass, and it is, when they remove it, they have dissected and removed the nerves also. So your management plan will change at the time of extubation also. Perfect. Over to you, sir.
So, Sagar, as he already asking you, suppose bilateral involvement is there, recurrent laryngeal. What would be your plan for extubation or the further management?
Sir, in these cases, we can leave the endotracheal tube in situ and shift the patient to ICU. And up
How long?
when, sir, it takes up to either up to I think 3 to 4 weeks for function to return. I may be overestimating the duration a bit. And when by direct laryngoscopy or video laryngoscopy, we can start seeing the movement in the vocal cord. After that, we can extubate.
Yeah, no, sometime it recovers. But if it is part of the surgical excision, definitely you have to do some permanent thing. Acha,
Yes,
you
sir,
talk about the retroexternal goiter. And in your patient, she's a lean, thin patient, so you could feel the lower end. But in a very obese patient and very heavy neck, you may not feel it. How would you know that it has some retroexternal extension? How would you know that? How will you assess that?
Sir, clinically, I would focus the sternal area. So normally it should be resonant. In presence of a retroexternal goiter, it would become dull. Apart from that, whenever it is suspected that we can have a retroexternal extension, we should get a CT scan. And the CT scan could also show us the degree of involvement or compression of trachea and the extent of the retroexternal goiter.
Yeah, that's a more appropriate answer. Yeah. And suppose the long-standing goiter and you are suspecting it has involved the tracheal rings and tracheomalacia is there. How would you know that it is tracheomalacia has affected the test would you like to do before observation?
Sir, from history, we can sometimes elicit a history of dyspnea in supine position, which is relieved on lateral shifting of the patient. So this happens because the tracheomalacia affected trachea is when compressed in supine position, there is decreased airflow. So patient experience.
Patient have already mentioned you that there is a high probability of tracheomalacia. I'm saying that. Now you are on the table and you want to extubate this patient. So just to confirm that it is tracheomalacia or only the patient's complaint, you are in very severe doubt that patient has tracheomalacia. What precaution you take? How will you assess that patient has tracheomalacia clinically, and then what
Sir, we can perform the Cocker's test, in which we apply pressure on the trachea and we listen for any stridor or decreased air entry sound.
Patient is operated. Patient is operated now.
A post-operated patient.
Okay, yeah.
Okay, sir. If we are about to extubate the patient and we are expecting tracheomalacia, so again, we can leave the tube in situ and not extubate until we have confirmed it.
The surgeon will not agree. The surgeon says you just extubate my patient.
Sir, we can leave a tube exchanger in situ and then remove the tube. And if the airflow is all right, we can remove the tube exchanger as well.
This is
how will you? But how will you? How will you? No, sir is saying that surgeon says just extubate it. So can you just tell me how will you convince him that, sir, this is not the right time to extubate? There is severe tracheomalacia, and I will try to wait for some time. So how will you convince me? Can you give me 5 points?
So this is physically.
This is clinically important also because you should do those 5 points to confirm that whether should I extubate on table or should I wait for some time.
Okay, sir. So we will physically press upon the trachea to feel the sensation of the trachea and the rings that is it appearing too soft on pressing.
How can you press? Can you just show me? You press your trachea and see whether it's tracheomalacia.
Like to squeeze the trachea, sir.
We have already said it is operated case. Surgeon will he will allow you to touch that operated area?
Sir. Okay, sir. So we can ask the surgeon if he hasn't closed yet.
Yeah. Welcome, Dr. Ajit.
Yeah, I'm joined. Sorry.
Take part and ask questions. So, Sagar, I'm coming directly. Do you know about leak test?
I've heard about the leak test, sir. I do not remember it properly.
When you were preparing for thyroid, you didn't.
Sir, it came upon in the literature several times, the leak test, yes.
It's very important leak test. So go back and read it because this is very, very, very important before concluding of any thyroid surgery. Am I right, Dr. Rakesh? Yeah.
Absolutely, sir. I think leak test is important. You should like for preoperative that patient on supine has obstruction, but on lateral recovers back. You check that when the patient is doing, when the surgeon is doing surgery, just ask them how many rings and how much softness they have. Then
he can feel it for you.
Yeah. And
Surgeon
then
can feel for you. Yeah.
yeah, and at the time of extubation, as sir mentioned, do a leak test where you check for the difference between the inspired and expired tidal volume, which should not be more than 25% of the difference between the two. If it is less than it is, this means there is absence of leak and hence tracheal collapsible. The other option is you do a fiber optic scopy through a tube and try to take the tube out and look exactly whether the trachea is anterior-posteriorly compressing or not. If yes, insert the tube back because your fiber optic is already in situ. If none of them is present, this means the trachea is okay. You can extubate safely. Sir is already there, so I hand over to him, sir.
Okay, sir. Hello, sir.
Yeah. Dr. Ajit, you can ask her. Yeah.
Yeah. I joined late, so what you have asked, I don't know. So what modalities he has got for the surgery? What anesthetic procedures he would like to do? Usually it is done under general anesthesia, but is there any other modalities he has at his disposal? What he would like to do?
Okay, a very good evening to you, sir, and welcome to the presentation, sir. Sir, apart from general anesthesia, we have regional anesthesia. It could be a deep or superficial cervical plexus block or a cervical epidural.
Okay. So you want to do deep cervical plexus block. How does that cervical plexus is formed? What are the levels at which the cervical plexus are to be the block nerves?
Sir, I'm
Did
sorry.
you get my?
Yes, sir. I understood the question, sir.
Yeah.
How many nerves would you like to block? How many levels would you like to block?
Levels you will like to block.
Yeah. Suppose you want a deeper block or superficial cervical, that is the one plexus. But for deeper plexus, you have to block many segments. So which segment would you like to block?
Sir, I think C4, C5, C6 segments we will block.
You are going too deep, too down, isn't so?
Yes, sir.
Have you ever read about it that?
Sir, not so well, sir.
Yeah.
Phrenic nerve supply.
In the deep cervical plexus block, there is high risk of phrenic nerve involvement, sir, which can cause respiratory paralysis. So that would again might necessitate intubation and general anesthesia. And
no, but deep superficial or deep cervical blocks are the modalities that is used for difficult cases and where we are the general anesthesia is contraindicated.
Yes, sir.
I think in addition to what you mentioned, if you block a phrenic nerve, what component of the breathing is contributed by phrenic nerve? Is it the only nerve which helps in breathing? You said if it's blocked, you have to intubate the patient. Is it always so?
No, sir, not always so. It is involved in the inhalation, deeper inhalation. So the patient can still manage with shallow breathing, and if the patient is comfortable and able to maintain saturation, we did not intubate.
Sagar, he's asking which component of the breathing cycle the phrenic nerve contributes. He's asking a very particular question.
Oh, in that case, I might not know that, sir.
It is diaphragmatic part.
Diaphragm.
Diaphragmatic part, yes, sir.
Yeah.
Okay, sir.
If you block one, you have to block both sides. It's a unilateral, then of course you can get away with one side. But suppose it's a midline tumor and you want to say total thyroidectomy, you have to block both sides. Is there any special concern? Can you block both sides?
Yes, sir. And we can block both sides, sir. And the drug can spread up to the superior laryngeal nerve, and that can make it difficult to visualize vocal cord movement during the surgery.
Then what will happen?
Sir, again, paralysis of vocal cords can cause stridor or difficulty in breathing, sir.
Yeah,
so
you can ask him.
Okay, you have talked about, you told me about the cervical epidural. Okay?
Yes, sir.
Yeah. At what level the cervical epidural is given and how much of the drug?
Sir, below the C7 level, and sir, drug, I am not aware what volume should be given.
Okay. You are blocking epidural, you are giving epidural at a very high level of the spine. Usually it is between C7 and T1. Okay. Usually we use a volume of 10 to 15 ml, not more than that. Okay. Yeah. Any other modalities that can be used?
Sir, we can supplement with these with local infiltration for smaller tumors.
Can we
And
do it under? Yeah, you are doing telling about that local infiltration. Can we do, a straightway question? Can we do it under local anesthesia? Which nerves are to be blocked?
Yes, sir. Sir, for very small tumors, purely under local anesthesia may be possible, but it's not a very popular technique, sir. We go with cervical plexus block, and what spared area we can cover up with local supplementation.
It can be done under local anesthesia. Okay. If you remember the nerve supply of the thyroid gland and that area front of the neck, then you can very much infiltrate the local anesthetic and you can do that. Okay. What is the nerve supply of the thyroid gland? You will come to the answer.
Okay, sir. So the thyroid gland is supplied by the superior laryngeal nerve and its external motor branch, and the recurrent laryngeal nerve.
Sympathetic and parasympathetic too. Which sympathetics and parasympathetics? Where thyroid gets parasympathetic innervation?
So parasympathetic from the recurrent laryngeal nerve. The motor
Recurrent
and
laryngeal nerve is a branch of?
The superior laryngeal nerve.
Superior laryngeal branch of?
Sorry, inferior laryngeal nerve. It's a branch of inferior laryngeal. It recurs upwards, backwards. That's why it's called recurrent.
Have you heard the vagus?
Vagus, yes, sir.
Yes, cervical 10. It is the parasympathetic.
Okay.
And sympathetic comes from the cervical segments. So that segment, if you remember, you can block it, locally infiltrate in the conditions where the patient is too debilitated and a patient is not fit for general anesthesia or cervical plexus block or epidural block. Here you can do the local infiltration, and if you go in the book, you will see the area of the local anesthetic block of the thyroid gland. It can be done under that. And superior laryngeal, recurrent laryngeal nerve will be blocked along with that. You have to take care of that, of respiratory difficulties, definitely. So, it can be done.
Yeah. You are talking about these injuries to different nerves, laryngeal part of the recurrent laryngeal or superior laryngeal. How to prevent them during the surgery? Is there any way?
Sir, there are two things we can do. First is clear identification and isolation of the nerve away from the surgical site so that there is no accidental injury. Apart from that, we have monitoring modalities.
Monitoring modality. What monitoring? Yeah.
Sir, what we can do, we can we can have visual monitoring by using a supraglottic airway along with fiber optic. And apart from that, we can have an endotracheal tube with external sensing electrodes present on it. So upon stimulation, the electrodes will receive the signal and tell us about the movement of it. Apart from that, we can directly place the electrodes into the larynx, which will, upon stimulation, sense the movement of the vocal cords and inform us about the status of the nerve.
Yeah. Is there any particular tubes or device which helps in the monitoring? You know?
So nerve integrity monitor is NIM is one of the devices.
Yeah, and the tube also, isn't it?
Yes.
Dr. Gupta, I think another 2-3 minutes, we will finish it up at 7:45. So you can ask.
Okay.
Yeah.
Yeah. After doing a surgery, you are taking the patient to the post anesthesia care unit. Okay. Hello, Dr. Sagar, can you
Yes, sir.
hear me?
Yes, sir. I can
Yeah.
hear you, sir.
So what catastrophes you expect there? As a resident, you are attending the patient in the post-anesthesia care. What catastrophes you are expecting there that may happen to the patient after thyroid surgery?
Okay, sir. Sir, there are several things we have to look out for. One of them is hematoma formation. At the end of the surgery, it is sometimes practiced to perform Valsalva maneuver and check for any bleeding. If a bleeding is persisting and forms a hematoma, it can compress upon the airway and cause sudden obstruction of the airway. In that case, we can do a bedside removal of suture. Apart from that, other things we have to look out for is hypocalcemia. If the patient is becoming hypocalcemic, he might complain of tingling and muscle spasm in the limbs, and it can even progress to tetany. So we have to look out for hypocalcemia in the post-op care. Apart from that, injury to the nerve can cause stridor or complete obstruction to the airways. So we have to look out for any respiratory difficulty, any dyspnea, or any additional breathing sound like stridor.
Not
Anything more?
hypocalcemia. It's a long process, chronic.
Sir?
Hello.
Yes, sir.
Yeah, I was other than the nerve injury, anything else can happen and
Sir, there can be compression of the heart due to hematoma. And electrolyte, like I said, hypocalcemia can cause severe tetany, which can cause respiratory.
Does it happen so fast in the
No,
post-anesthesia
sir,
care?
up to 24 to 96 hours as per the literature, the time it takes.
Yeah. So not the
Yeah.
immediate one.
Not
immediately. In the
Yes,
post-anesthesia care unit, it doesn't.
It occurs
Whether you are doing a hypo in a hypo condition or hyper condition, I was not there. So in a hyperthyroidism, do you have heard about the thyroid storm?
yes, sir, thyroid storm.
What is thyroid storm?
So, sir, thyroid storm is an exaggerated thyrotoxic features in the patient. It can present with tachycardia, congestive heart failure, shock-like condition, severely decreased vascular resistance, and altered mentation, sir. So, and
What about
hypothermia.
Hypothermia. So
Yes,
what differential diagnosis you are going to do with this condition? Whether it
sir,
is
the first differential diagnosis I would think of is the malignant hyperthermia.
Yeah.
And apart from that, if it happens in intra period, we can suspect light plane of anesthesia. And one less common diagnosis would be neuroleptic malignant syndrome.
Neuroleptic malignant syndrome.
Yes.
What about the pheochromocytomas?
Pheochromocytoma as well.
Differential
Yes,
diagnosis in thyroid storm is say it is a differential diagnosis. And what
yes,
about the and what happens in thyroid hypothyroidism?
sir, myxedema coma is a crisis that can happen in hypothyroidism.
Okay.
Sir,
So
yes.
what management do you do for that thyroid storm?
For the thyroid storm, we have to give both type of drugs. First, which inhibit the synthesis of thyroid hormone, and second, which prevent the release of thyroid hormone. So we will give propyl uracil around 200 milligrams start dose, followed by smaller doses, 50 milligrams, and through nasogastric tube. Or apart from that, we will give potassium iodide solution to prevent release and slow down the peripheral conversion. We will give beta blockers to manage the adrenergic features and to also decrease the conversion of T4 to T3 peripherally. It is to be mentioned that beta blockers cannot use as a prophylaxis for thyroid storm. They are not known to prevent it. They can only be used for management of it. We would also use steroids because they prevent the decrease the conversion of T4 into a more active T3 form. So we can give hydrocortisone 200 mg stat dose followed by smaller dose 6 hourly. Apart
What
from that,
about the hypothermia? How you are going to do it?
Sir,
May I
hypothermia,
come
we
in,
will
sir?
use cooling blankets and external cooling, air cooling.
Cold
Sir, may I
plus.
come in, sir?
Yeah.
Ajit sir, may I come in, sir?
Yeah. Yeah. Sure.
Actually, sir, we have already crossed the time. It's all
Okay, sir.
till 7:30. It's 7:48 now, and we have expert Dr. Rakesh Garg with us
Yeah.
also. See, he
Yeah.
has presentation. So can we conclude this session, sir, with your permission, sir?
Yeah. Sure.
Thank you very much. Thank you very much, sir.
Okay.
First of all, I would like to inform everyone that our President-elect, Dr. Bhimeshwar, sir, is with us. And we have esteemed faculty and members, senior members of Bihar and Jharkhand Society is also with us, like Dr. Manoj Kumar, Dr. Dev Sanjay Nag, Dr. Srividya, Dr. Damodar, and Dr. Nishan Sahai, and Dr. Gurmukh. Many senior faculty is with us also. So, sir, first of all, welcome to Dr. Bhimeshwar again. And Dr. Manoj, would you like to say something? Dr. Manoj? Dr. Nag? Hello?
Yeah, am I audible?
Yes, Dr. Nag is our scientific chairman also.
Yeah, audible.
Yeah.
Yes.
I welcome to the esteemed ISA national leadership and the state leadership also. And I think this is an extremely welcome initiative from Dr. Sharad and his team to have such postgraduate discussions. I think with this, the postgraduates from a state and people presenting, they are at par, possibly not only in the country, I would consider the best anywhere. The quality of the discussions and the answers also, the preparation, that is phenomenal. I myself am also a postgraduate from this state itself, and I can see how the education, the teaching in this state, it has gone up leaps and bounds. It's an honor for all of us, and I thank the state branch for bringing this forward. Thank you so much.
Thank you, Dr. Nag. Now I request our moderators, Dr. Jardin and Dr. Ajit Gupta, to say a few words about Dr. Sagar, how he has prepared, how was your remarks, and also Dr. Rakesh Garg. Please give your genuine remarks for Dr. Sagar. I know he has done extremely well, very well prepared, very confident. And really, we all are really proud of you, Sagar, but wanted to hear from Dr. Jardin, Dr. Gupta, and Dr. Rakesh.
Yeah, Dr. Gupta, you first your.
Yes, sir.
Yeah.
Yeah, I joined a bit late, but the way he was answering, his body language was there. And definitely he was doing remarkably well. And of course, he's a second year postgraduate. He needs to be upgraded every time. And he will, I think the way he is doing it and he has presented, answered the questions, he will be doing very well in future also.
Dr. Rakesh, you are from beginning. Your comments regarding his performance.
Sir, I think he has performed well, but I will just not be buttering him because he's a second year student and there is no limit of the extent of learning. So there is one thing in the exam, something called pass and fail, and pass and fail is 50%. But there is much more beyond it, right? There is something called distinction, which is 75%. And there is something more than that, which is 100%, which is an uneventful patient outcome. And there is nothing called 75% or 50%. It has to be 100%. And that comes with little more skill and experience. So knowledge is one. And if you see towards Dr. Ajit Singh and Dr. Jadon with so much of experience, the complication rates and the outcome improves with time. So I think you have done fairly well from the confidence level, from the way you are answering. It is absolutely well. Now, what you need to do is you need to translate this knowledge into your clinical experience so that your outcome becomes good. So because theory is definitely one thing, but when you really face a thyroid storm, you have to manage it within the next 1 to 2 minutes. You cannot wait for some time, and you have to think that what needs to be done right now. Second thing is, we have not discussed this thing today, there is always something called recent updates, and there are always some controversies, which probably we have not touched today. Like, for example, you mentioned about the neuromuscular monitoring. Now there are specified endotracheal tubes where we can use them. They have some benefits, but they are not into routine clinical practice. So we should be aware both sides, that these are the advantages and these are the limitation of these tubes. And something simple, like for example, how to do a fiber optic, what will be the 3D reconstruction of the trachea airway in thyroid swelling, what is the role of virtual endoscopy? When we're asking these questions, these are the recent updates which are not into clinical practice, but they are sufficient data that they probably would come in some of the cases. So when you go for a distinction viva, I know you are absolutely pass in your exam, no confusion about it, but think of something more as a distinction viva. So when you say distinction viva, it should come up that I will look for a virtual endoscopy. I can ask for 3D endoscopic pictures in these films to look for that what is the dynamic nature or what is the static nature. So those headings and terminologies are important when you appear in the exam. And as Dr. Ajit sir were asking, when you answer in the exam, there are two ways to answer in the exam. One is you enumerate what you know. Second is you tabulate what you know and then answer it. For example, if you want to say, I'm just giving a very vague example, that nerve supply for particular organ, you should say that it has a sensory supply, it has a motor supply. Sensory supply comes from this dermatomes and they're supplied by these nerves. Motor supply comes from these dermatomes, these nerves, and they are supplied by these nerves. So when you see in a heading format, everybody's know that you know sensory, it has a sensory component, it has a motor component. But on the other side, you say it's a cervical plexus nerves, it has a recondylal nerve, and these are the nerve supply. So this will give you a very, answer is right. Nobody is going to fail you. You are absolutely right answer. But if you speak in a more systematic way, probably you are going on to a distinction viva. And that is what we can refine always. We can polish you always. And I think I must acknowledge and appreciate my teacher, Dr. Ashok Jadon and Dr. Ajit Singh. I have heard them in so many platforms that they were guiding you, they were exploring you so that you come up with the right answers, and you have done very well. Thank you.
Thank you, sir. Thank you for the feedback.
For me or from me, Sagar, you perform well. But what the words of wisdom from Dr. Ajit and more from Dr. Rakesh, I think you have to keep in your mind more tighter way. Because I was just touching advances, but I left it for Dr. Rakesh to enumerate and enlighten us further. I asked you the particular tube. That was the intention to take you that direction. But you performed well, but there's a very, very long way to go and achieve the distinction. So that note, we conclude this session and we will go for the next session. Dr. Sharad.
Thank you, sir. Thank you very much. You, Dr. Bhimeshwar, would you like to say something? Sir, please unmute yourself.
By and large, Dr. Sagar has presented very well, but there are certain small mistakes which he had done, which was one thing I said was Malampati grade 4, he said. But the mouth opening was not adequate. It was only 1.7. So he need to collaborate both the things. Some of the examiners are very particular about certain very minor things. And second thing is about the basic thing about thyroid, basic anatomy, physiology of thyroid. What are the thyroid hormones secreted and all. Though the examiners have not gone into that aspect of it. But whenever a long case is given, thyroid or liver or whatever, we usually start off with the basics of anatomy and physiology. So, Dr. Sagar, I'm sure he might be knowing all these things, but we keep in mind that these will be the basic questions which will be asked first, and then you will be taken into the anesthetic management. Okay. So, supposing you are failing in your anesthetic management and all, they'll again fall back to the basic. So, you have to start off with your basics. Keep it in mind, and it's only an advice. You have done really well. Thank you very much, Dr. Sharad.
Thank you, sir. Thank you, everyone. Thank you, Dr. Jardin, Dr. Ajit Gupta, sir, and Dr. Rakesh Garg for filling the time. Thank you very much. And Dr. Bhimeshwar, thank you very much. So we are moving to the next session, the expert session by Dr. Rakesh Garg. And I'd like to invite Dr. Ashok Jadon sir. He is the moderator of the session, to welcome Dr. Rakesh Garg sir and give his tell the audience about the Dr. Rakesh Garg and his.
Thank you, Dr. Sharad. Once again, I welcome each and everyone, all the senior faculties present here on this 16th session of our CME. And at the same time, I will be moderating a person or introducing a person. It's my proud privilege to introduce Dr. Rakesh Garg. He doesn't require any introduction in this forum. He's a well-known, I think, on the top few academician of the country, but it's a formality, so I have to do that. Dr. Rakesh Garg is additional professor in All India Institute of Medical Sciences, and he is a very distinct academician. He has published more than 260 publications in international and national journals. He is a teacher par excellence. He is great in the difficult aspect of anesthesia, which every one of us fear in the methodology of the scientific publications. He's a great guide. He often guided me and helped me whenever I face personal difficulty. He is always available to help personally. He is my personal friend also, other than the well-known academician in India and abroad. So without wasting time, because if I start reading his awards and achievement, it will take at least half an hour. So Dr. Rakesh, without wasting time, you please enlighten us. You have given few hints, but now the stage is for you. So I will welcome Dr. Rakesh. Yeah, over to you, Dr. Rakesh.
Thank you so much, sir, for your kind words. And thank you all the dignitaries, Dr. Bhimeshwar, Dr. Sharad, Dr. Dinesh Singh, Dr. Manoj, Nishant, and all the dignitaries of ISA Bihar, Jharkhand, and senior members, Dr. Ashok Jadon and Dr. Ajit Singh. Thank you so much for the kind words and inviting me to this platform. I think Dr. Sagar has done a great job by answering the various questions very nicely. But just I want to say one thing, that thyroid is such a case that it will definitely be there in most of the exams in some way or the other, whether it will be a theory exam or it may be practical. It will be somewhere or the other. So I think this is already a leaked question that you cannot escape from a thyroid case for your exam purpose. Even in the practical viva, you may get an X-ray with the soft tissue neck. You can get an PFT loops. You can get an ECG of thyrotoxicosis. So there will be variable presentations. So please prepare your thyroid course very well, starting from the basic, as Dr. Bhimeshwar was saying, and going to the updates, as Dr. Ashok Jadon and Dr. Ajit Gupta sir was mentioning, that you need to know it very well. But as a clinician, this is one of the commoner surgeries, if you see, especially in India. It is being operated and seen by various specialties because of either the reconstructive surgeries or the primary thyroidectomies, and even it will be at times getting into a critical care unit for various complications, as we were just discussing about the thyroid storm in these patients. They may come up and end up there. So clinically also these cases though appear simpler most of the time, but they can be challenging at some point of time. So for example, let's see this case, in addition to what Dr. Sagar has mentioned, 65-year-old male, 58 kg, progressively increasing swelling over neck for the last 50 years, and it has a sudden increase in the last 6 months. There were some obstructive symptoms, difficulty in speaking, swallowing, and breathing for the last 6 months, and patient was clinically euthyroid. The FNAC shows hyperplastic nodular colloid goiter. Airway assessment shows modified Mallampati class 2 neck movements were restricted because of this large neck mass. And indirect laryngoscopy, which we were discussing in the case also, it shows fixed left vocal cord and left pyriform fossa was not opening up, probably because of this large defect. So this is an important finding that we should always review, because this will help us to make a plan for extubating these patients also. You should also see for these, you can see that the neck veins are extended because are distended because there are some venous obstruction. So the congestion will lead to the formation of collaterals, and hence this becomes an important issue in your assessment also, that you should make a note of it. Also, you should be aware as an postgraduate student that how to evaluate and assess the soft tissue neck X-ray. You should be looking for the various compressions and deviations on these two X-rays, which are the epilateral views of the soft tissue neck, where you can make a note of the air shadows that depicts there will be a deviation of the airway and probably a compression, and that will lead to your airway management plan as plan A, plan B, because it will be a difficult airway. These patients usually will come for total thyroidectomy. And then to start with, from the exam point of view, as we were discussing in the case also, the anatomy of the thyroid should be known to you, that how it appears and what are the tracheal rings on which the thyroid usually sits. So that is important aspect, and you should always be knowing, because when we are now discussing about the recent updates, the ultrasonography has emerged as one of the tools for looking for the isthmus of these patients while we are doing any procedures, emergency procedures like surgical access for the airway on the anterior of neck. So you should be very, very clear that when you're doing, say, PCTs in these patients who have otherwise thyroid mass, but is admitted into a critical care unit for some mass, you should be knowing that at what level you should be cautious, because there could be a thyroidema artery also. So hence, knowing the anatomy is important for these patients for your management. Also, we should be very clear that what are the blood supply to thyroid gland, because this sometimes can come a long question. And also, as we were discussing, you should be very, very clear about the nerve supply of these structures. Now, when we talk about the thyroid disorders, you should be looking for, because we have just discussed that the thyroid disorders can manifest as euthyroid, it can manifest as hyperthyroid or hypothyroid. And in addition to it, because of certain stimulus, it could be a crisis situation. Also, you should be aware when we talk about these malignant tumors, certain of these patients would be on thyroid suppression treatments. So what impact will it have on the various cascade of the thyroid hormone release, which is primarily controlled by hypothalamus, which affects on pituitary, releases the stimulating hormone, and then it acts on the thyroid, which leads the formation of the thyroid hormones, which are converted into its active form in the peripheral tissues, and which has a physiological effect. And this physiological effect have effect on the cardiorespiratory system, on the metabolic system, which will be coming a little later. Now, here you need to understand that when we talk about these structures, what will be the negative feedback loop in certain situations? We were talking of the Mann syndrome in our discussion. We were talking about the impact of other disease conditions in the patients with these effect on the thyroid disorder. Also, you should be very, very clear with this cascade that what happens during the thyroid hormone secretion. I think this is a wonderful table. This is present in almost all books, including your Miller book. It is also in pathology book. So you should be very clear the steps of the various steps of the formation of the thyroid hormones, including the trapping, then its action with the various enzymes there, and then how the various coupling, endocytosis, proteolysis, secretion, and then its release into the tissue, wherein in the peripheral tissues, it is converted further into a physiological active form from T4 to T3 by deiodination. So these steps should be very, very clear to you, because sometimes we'll be using these one as a part of treatment modality. So these all steps must be clear when you're talking about in the exam about the thyroid disorders. I may not be going into details or reading these words, but for the exam purpose, when you talk about the thyroid hormones, you should be clear that which hormone are we talking about, which hormone is most commonly secreted by the thyroid, and which hormone is more physiological active in the peripheral tissues, and how they are converted. So thyroxine is 90% of the hormone secretion, and then T4 is converted into T3 in the peripheral organs, where it brings about its physiological action. You should also be aware of the other hormones like reverse T3 and calcitonin parafollicular cells, which is involved in calcium metabolism. Because when we talk of the secretory tumors, sometimes though these are minor, but they can have effect on the various structures. Primarily, the thyroid disorders sometimes usually manifest maybe in the form of euthyroid, like multinodular goiters, but at times it could be hyper or hypothyroidism. And when you want to classify these conditions, you need to remember it has an anesthetic implication, because as an anesthesiologist, you will be asked that this is the TSH level, which the patient fit for elective surgery, or if the patient is even posted for other incidental surgery, if the TSH values come somewhere, say 4.5 or 5, are you going to take up the patient? What precautions will you take? Will you try to optimize this patient starting on some drugs? So these are the things that you should look for. So usually we say that overt hyperthyroidism is when the TSH level is less than 0.1. Overt hypothyroidism is when the TSH level is more than 4.5. And in between, it will be subclinical hyper or hypothyroidism, which sometimes will manifest in a stressful situation. So this is what you should be aware of, not only from an exam point of view, but from the clinical point of view. Now, when we talk about the impact on the body tissues, this is what you need to assess in the history. And this is what you need to speak in the exam also. Now, when you speak in the exam, it will be a good idea if you can tabulate the effect of the thyroid on various organ systems. So you may start with cardiovascular system, you can start with liver, you can start with kidneys, you can start with intestine. So if you can just put up into this categories, it will be easier for you not to miss a particular effect of the thyroid disorder on various organ systems. Definitely, Sagar has very nicely described and spoken about various manifestations of hyperthyroidism and similarly hypothyroidism. So when you are assessing these patients, you should be looking for these signs, because in the perioperative care, many of these signs will have clinical implication. They will require change in the anesthetic management, and the monitoring will be required for these patients also. And hence it becomes very, very important to look for these signs. Now, why I'm saying these signs? Because a patient with hyperthyroid may be posted for an emergency surgery, the other incidental surgeries, and he may be having a tachycardia. He may be having some changes in the cardiovascular system. He may be having some GI system with diarrhea leading to dehydration. And if you want to induce this patient, they can manifest in the form of sudden hemodynamic collapse when you try to induce these patients. So that's why you need to look for these signs and symptoms in case if they are posted for emergency surgery. In case if they are posted for an elective surgical procedure, you should look for that many of these signs will be on a settling phase when you try to treat these patients for either hyper or hypothyroidism. Many of these signs and symptoms will take some time, but some of the symptoms will try to settle down faster, and hence you should look for the optimization features or trends in these clinical findings, so that you can say that now probably the patient appears to be okay and patient can be taken up further for surgical procedure. Remember here that when we talk of the hormones levels and the laboratory values, TSH remains the most sensitive aspect, which you can follow up for measurement of these patients, but usually it will take some time. So it has to be correlated with the clinical symptoms also. We have already discussed about the compression of soft tissues. So these are the various structures which can be compressed by an enlarged thyroid, and hence you should be looking for impact of these organ systems, and you should try to elicit either by clinical examination, and sometimes we do imaging also to look for these type of compressions. Flow volume curves used to be one of the earlier conventional modalities, but now we are moving to other imaging modalities to look for these features in addition to the flow volume curves. But it will be a good idea from the exam point of view that you are aware of, depending upon the site of obstruction, you are able to draw the graph of flow volume curves and look for that which type of obstruction these patients are manifesting. Now, these are the various clinical methods that are required for the examination of a patient with thyroid mass. So you should be very, very well versed, and you should be able to demonstrate in the exam these various palpatory findings and their interpretation also, that how these will impact on your perioperative management. Whether we talk of Pemberton Sign, by the focus test, you should be able to identify and make a clinical examination accordingly. Also, you should be able to find various tests that will be giving you a clue of the compression of soft tissues, maybe based on the clinical examination or symptoms. For example, if a patient says that he has increasingly been having dysphagia for last couple of months, and he is not having any other issues except a thyroid mass. So probably it appears that it is a compressive mass or obstruction of the esophagus because of the enlarged thyroid. If a patient has a hoarseness of voice, probably rectolaryngal nerve is being affected. The patient is a Horner syndrome, probably sympathetic trunk is affected. So you need to look for all those features because they are going to affect your perioperative management. The eye sign, which is very, very conventional, because when the patient is being operated under general anesthesia, you should be very cautious. These sometimes, especially the patients with hypothyroid, they have wide open conjunctival spaces and they may have corneal injuries. And hence, assessment of these signs are important because they will show you an idea the status of patient's thyroid status, and also special care would be required during the perioperative period so that you are not further hampering the eye as such. The diagnosis of thyroid is primarily based on clinical and laboratory methods. Sometimes when we talk about Mann syndrome and other special situations, we also need for special tests, which I will be coming a little later. The imaging modalities has been also an upcoming very important modality for assessing these patients, specifically in the malignant cases, because you have to look for the extent of tumor, you have to look for its resectability. There may be involvement of trachea, there may be involvement of the lymph nodes, and hence imaging is also an important modality for managing these patients for further surgical operation. Now, in the laboratory techniques, I think this is the standard table mentioned in your books. I may not be going into detail for this, but based on the levels of TSH levels, free T4 levels, you are able to make a diagnosis. Now, remember, when I talk about the free thyroid levels versus total levels, these levels, why we need free T4 levels? Because these are bound with the proteins. So in case if there is any nutritional change, any stressful event, the total levels may remain unchanged, but the free levels will provide an accurate measurement of the change in the thyroid levels. And hence it becomes very, very important, not only look for total hormones, but it will be a good idea to look for the free hormone level in these patients to make more appropriate diagnosis for clinical management. The other functions that I was talking about is the RAIU, which is required for these patients. Sometimes we also look for the urinary excretion of the RAI in these patients, and accordingly we can make a diagnosis. Remember that when we talk of these indicators, the free levels, they are very good indicators of hypothyroidism, but not a very good indicator for hypothyroidism, for which you will require other types of investigation like reverse T3U for these patients as well. TSH remains one of the best indicator for patients with hypothyroidism, and it will increase more than 5 micro units per ml in case patients manifest hypothyroid patients. The thyroid scan is also done for looking for the total extension of the tumor at times, especially the malignant part, because it will help in to make a diagnosis of surgical decision for the resection for these patients. Sometimes the other tests, which are more for clinical medical management of these patients or looking for the etiology for hypothyroidism, sometimes the other tests are being done, which are usually the antibody titers to look for why this patient is manifesting a symptom of hypothyroidism. The test, which also includes the, nowadays more commonly are used, the ultrasonography. Ultrasonography is one of the tests which brings out differences between solid versus cystic masses, and they also help now the guided biopsy can be done using this modality. The other important features that we have just discussed in the exam also, that you have to differentiate between a benign and malignant tumor, and we have already discussed this table in the exam. And when you are assessing as a part of your PAC, you should be looking for these differences, because this is going to make a difference in the management, which includes the clinical management, which includes the airway management, which also includes the modality for extubation in these patients. And hence you should be looking for the differences, identifying that it appears to be benign growth or a malignant growth. When we talk of the thyroid malignancy, the most common malignancy is the papillary type of malignancies. Though the prognosis is very good in these patients, On the other hand, anaplastic type of malignancies are very aggressive, and we see in our clinical practice that even at the time of their first presentation, they're already metastatic to nearby organs, and they have very, very poor prognosis. On the other hand, papillary remains a good prognostic one, and usually these patients can be operated, and at times, even with the residual mass, they can be started on certain medical therapy, radioiodine therapy, which provides a good option for taking care of ablation of the residual mass of the thyroid. We're talking about the Mann syndrome, so you should be aware of that when you are evaluating these patients, if patient shows multiple endocrinal abnormalities, they may be part of multiple endocrine neoplasia. And hence, if you have any suspicion, for example, a patient may be showing fluctuating blood pressures, right? Then probably this patient may be having a pheochromocytoma also. If patient is having a calcium disorder, maybe there could be a parathyroid gland disorder also. So now individually, these may not be three different disorders because this is a part of something called Mann syndrome, and hence needs to be evaluated as a part in totality. Now once we have make a diagnosis, what we should do for the anesthetic management, what are our considerations? Now, we have already discussed during the discussion that these patients, the consideration, so this is important for the exam point of view. So when we say that if this patient is posted for surgery, what are your concerns? So probably you can divide them patient-related, surgery-related, anesthesia-related, and hence you can point them one by one. Patient-related, maybe patient is on certain drugs, patient could be prone to arrhythmias, patient could be having hemodynamic perturbations, and then based on this, you can take a decision that what needs to be done. For example, patient with hyperthyroidism, he may be on beta blocker. The patient may be on antithyroid drug, right? Patient may be a little prone because of tachycardia, because of more sensitivity of myocardium, and they are more prone for manifesting arrhythmias, and they are having hyperdynamic circulation. They may have hyperpyrexia, right? So these are the certain concerns. Their metabolism is little higher. Their oxygen reserves become less, and as they are more prone for increased oxygen consumption and more prone and faster for desaturation in these patients, and hence requires caution. For surgery related, you should be cautious about these patients, that these patients may require an elevated head and neck position. They may have a higher chance of venous air embolism. The blood loss may be a little more in these patients because they have hyperdynamic circulation. There could be a risk of thyroid storm, which we were discussing about. And depending upon the extent of tumor, they could have effect on the surrounding structures. Anesthesia related, they could have difficult airway. There could be a possibility of vocal cord palsy. We need to be very cautious while inducing these patients because they have a hyperdynamic circulation. They may have tachycardia, and hence they may show a response which can stimulate sympathetic nervous system, which is already active in these patients, and hence you should be cautious of these concerns in managing your perioperative care. On the other hand, when we talk of hypothyroidism, probably there will be a reverse of it, but some additional concerns will also be there in these patients when you talk of hypothyroid patient. So in exam, you should try to enumerate them in this systematic way. And this will also be helpful for your clinical practice, because if you know that these are my concerns, we will be able to manage these patients. For surgery related, these patients, if you talk hyperthyroidism, it was the thyroid storm. If you talk of uncontrolled hypothyroidism, it will be a myxedema coma. There could be a chance of neuropathy, there could be a chance of hypoglycemia, and hence you should be very, very cautious. These patients are also prone for hyponatremia. Anesthesia related, these patients are very sensitive to myocardial depressant effects of various inhalation agents, and hence you should be a little cautious. They may not tolerate fluid too much because they have diastolic dysfunction, and hence you should not be very overzealous managing these patients of hypothyroid because they will be showing a little less heart rate, a little less blood pressures, but if you give a lot of fluid, they will manifest in the form of pulmonary edema and cardiac failure. And hence you should be very, very cautious in these patients because they can manifest bradycardia also. The surgical options for thyroid, why these patients are posted for you, it could be a lobectomy, it could be a near total thyroidectomy, it could be a total thyroidectomy, or it could also be in a malignant situation, total thyroidectomy with lymph node resections. And hence your management will be a little different depending upon the situation. Now, majority of time, you need to ensure a euthyroid status in these patients and look for that the patients presenting features are on the optimized status, right? So the perioperative homeostasis is achieved in these patients so that the patient is not manifesting uncontrolled symptoms because of the perioperative interventions. So what you need to do is you need to look for that whether it is controlled or not, what's the urgency for surgery, whether it's elective or emergency surgery. And as we were also discussing in our discussion section, that what approach for anesthesia you should look for, whether it should be general anesthesia based or whether patient has a high risk for general anesthesia. We are looking in a specific group of population as a regional technique or a combination of both, regional for pain management and general anesthesia for providing stability to the patient. The airway remains a big issue, and hence we should be very cautious. Post-operative problems, we should be predicting it. We have discussed in the exam also, and you should be cautious about those things. With regards to the investigations, you should be looking for the routine investigation. And very recently, we do have our guidelines from the Indian Society of Anesthesiologists. So those are the routine investigations. But a patient with thyroid, you should be looking for a TSH level, which is one of the sensitive marker for the euthyroid status of a particular patient, in addition to the clinical things that we have mentioned for. You should also be looking for the findings of the airway difficulty, including the effect of vocal cords. In case if you are looking for the malignant cases, always try to have a look on the CT pictures, because that will not only give you the extent of tumor, but that will also give you the extent of the malignancy and its effect on the airway, and you can manage them properly. Majority of times, because these patients would have some issues on the airway, sedation is not routinely required for these patients, but do consider aspiration prophylaxis for these patients. Monitorings are very routine, but we have considered some specific monitoring for these patients. If you talk about the ECG, these patients may manifest arrhythmias, especially the hyperthyroid patients, so to look for. Temperature is the other thing. Capnography is one of the important aspects, because when we will come into the thyroid storm, this is one of the important features that you should be looking for. And at times, the central venous pressure is not routine monitoring for these patients, but in a selected group of patients with uncontrolled thyroid, you may need to have invasive blood pressures also. The most important technique, conventionally acceptable, is general anesthesia, plus minus regional anesthesia is the modality for pain management. But in selected group of population where general anesthesia is having a very high risk, case reports has been published, the data is available where regional anesthesia alone has been used as a modality for operating on these patients. The conventionally thiopentone has been found to be safe, but you can use propofol. Try to avoid ketamine, specifically in hyperthyroid patient. Succinylcholine can be used for these patients. Even the non-dilphorid like vicronium is useful. But try to avoid those drugs which has sympathetic stimulation. You should always obtain the pressure response in these patients, because patients with hyperthyroidism, they will manifest a sympathetic stimulation, increase in the hemodynamic status, and they can throw up arrhythmia. So be cautious in these patients. Also during the airway management, ensure if it's a large thyroid mass, this is one of the basic principles, that your tube tip should be beyond the thyroid level, so that if there is any compressive symptoms, it will not be compressing and leading to airway obstruction. A use of flexometric tube in this situation would be a better idea. The drug effects, you should be aware as an examiner, examining that which are the drugs which has an effect on various effect of the thyroid status, and how the anesthetic drugs has a no interaction between them. These drugs may cause various hemodynamic perturbations, and hence you should be cautiously using them. The patient's management of hypothyroidism, try to avoid those drugs which can stimulate the sympathetic nervous system. Try to have a good pain relief in these patients, because they will be showing hyperdynamic circulation. Any stimulus leads to further exaggeration. Be cautious about the volatile agents. Isoflurane, desflurane are good, as they will not have effect on the sensitized heart, sensitized myocardium, and hence arrhythmia chances will be less with these patients. Do monitor these patients of hyperthyroidism, because these patients can manifest thyroid storm, and vigilant monitoring is more important for these patients. In case if these patients have an increased amount of blood loss, you should be cautious that which drugs should be used, because it could be an exaggerated response in these hyperthyroid patients, and hence you should be using them appropriately so that the exaggerated sympathomimetic response is not being seen, and phenylephrine remains one of the good drugs. Positioning for the surgery is important. The head-up position is maintained because it leads to better exposure, lesser amount of bleeding. But remember, sometimes it can lead to more amount of venous air embolism if there is venous injuries. Ensure that the head is nicely placed, the corneas are well treated, and there is lesser chances of injuries to these patients. We have already discussed in the class itself today that the deep and superficial cervical plexus block are one of the modalities for providing specifically analgesia, but at times anesthesia also in these patients. Do look for various complications that can happen, like bloody arrhythmias, excessive bleeding, acute hypotension, air embolism, and most dreaded the thyroid storm also. So we have discussed certain aspect of thyroid storm. You should be looking for, you should be knowing that why this situation happens and what is the primary pathology for it. It is primarily a hypermetabolic state which involves multiple organ system because of the stress of perioperative period on the thyroid, leading to thermoregulatory failure, leading to cardiovascular collapse, and leading to metabolic failure. It usually occurs in post-operative period, but can be intraoperative period also, and hence you should require a very, very important vigilance for early identification and managing these patients. Now, there are certain factors which precipitate thyroid storm. You should be trying to look for those things and try to control or manage in the perioperative period. And these factors should be taken care of so that you can provide thyroid storm. Now, also intraoperative, there will be certain factors that can lead to more amount of thyroid storm, like inadequate depth of anesthesia, hypoxia, hypovolemia, pulmonary embolism, excessive surgical manipulation, and hence you should be cautious in case if this happens, this patient remains prone for thyroid storm. There is a criteria by Bjsa and Markowski criteria for thyroid storm. So this is a diagnostic criteria to confirm that this is thyroid storm, not just because of the metabolic stimulus or because of the surgical stimulus. And you can use these parameters. You can use these parameters, and the total score in this different format is more than 45. It indicates that patient is a diagnosis with thyroid storm and you need to manage it. Now, differential diagnosis of thyroid storm, because we were talking about the Mann syndrome, so you should be looking for the pheochromocytoma, carcinoid crisis also. At times, it could be a malignant hyperpyrexia. So look for the features which differentiates between the two. The preventive strategies should be followed in these patients, right? Try to ensure that patients remains euthyroid. Check for the sleeping pulse rate. This is one of the important parameters that needs to be seen in hyperthyroid patients, that whether this increase in the pulse rate is because of anxiety or it is a baseline rate. And that is what the conventional observation of sleeping pulse rate is important for these patients to assess for the effect of hyperthyroid on the cardiovascular status. Also, you should be cautious about the other preventive strategies like avoiding the sympathomimetic drugs, avoiding the various drugs that can lead to the occurrence, which we have just discussed about the various precipitating factors. Once this occurs, you should be knowing that how to manage it. The first step would be halting the production or the release of thyroid hormones. Look for management of heart rate. You can use various beta blockers for that same. In case if the atrial fibrillation happens, you can use digitalis. If it is hemodynamically unstable, a cardioversion may be required for these patients. And then look for other symptomatic management, inhibiting the hormonal using iodide, aggressive cooling of these patients because they will be hypothermic. And at times, if the patient's symptomatic is not controlled, a therapeutic plasmapheresis may be required as a rescue measure in case if the patient is remaining unstable even after these surgeries. Also remember that at times, if it's not an emergency surgery, you should try to make the patients not only biochemically euthyroid, but also look for the cardiovascular system that has been well controlled using various agents. Now, coming to the last 2 or 3 slides regarding the airway management, I may not be going into detail because of the shortage of time, and we have discussed certain aspects with the presence of specialized tube. When we talk of the airway difficulties, these patients of thyroid mass, large mass, or the thyroid infiltration, they can have a difficult bag mass ventilation. They can have tracheal compressions or deviation. They can lead to the possibility of difficulty ventilation through them. They can have postoperative compression of the trachea, which is labeled as tracheomalacia. And for this, you should look for certain investigations. I have just discussed in my discussion also. The emerging modalities is something called a check fiber optic scopy, which provides a dynamic stature of these patients. So this can be done at times to look for that how much is the tracheomalacia, because this is a dynamic structure. And this cannot be seen on your CT scan because CT scan remains a static imaging. So nowadays we have emerging modalities of using these tools for looking for the dynamicity in the airway collapsibility, and hence it is upcoming field that can be used for these patients. So these are the brief things for from the examining point of view, we should remember, and you should not try to tabulate them in these points so that you are able to complete it in whatever form. And if it comes in the form of your long questions or short question in the exam viva, in the exam in a theory question, you try to tabulate in this way. And we have discussed certain updates during our discussion section. And if you have some questions, I think we are open to answer it. So any comments or any questions from anybody?
Yeah, thank you, Dr. Rakesh. You have covered the topic very comprehensively and completely, I would say. And I must compliment and thank Dr. Sharath to plan in such a manner that the presentee will know that what are the deficiencies and how far he has to prepare. With that remark, it's over. Excellent presentation, Dr. Garg. No, I have no words to express my feeling about this satisfaction and completeness of the presentation. So over to Sharad now.
Thank you, sir. Thank you very much. Thank you, Dr. Rakesh, for excellent presentation. It's really great listening to you always. And now I want to invite Dr. Manoj. Dr. Manoj, are you there? Hello? Okay, never mind. Dr. Dev Sanjay Nag, our scientific chairman, would you like to say something?
Yeah, thanks to Dr. Rakesh for the wonderful and fabulous presentation. I don't think anything has been missed. And these videos should actually be captured for all MD students and DNB students, even for junior consultants, for them to see and learn how these cases have to be taken up. Now, two quick questions. I'll not say questions. These are small queries, not only personally, for others also. One is an asymptomatic patient is selected for an elective surgery like a lap chole. What is the cutoff level for a TSH we should take? Because we have been hearing varying opinions from endocrinologists, surgeons, and anesthesiologists. The second question is relatively new, one of the newer modalities, although it has come up from dental for last 2 decades nearly. What is the role of CBCT? Because they can give you good CT images till up till the sternal notch. And we in this hospital have acquired it very recently, and I have seen some of these images of the airways. It gives beautiful 3D reconstruction of the airways. Although literature, there is not much evidence. So what is the role of a 3D and CBCT image reconstruction for such cases, especially in thyroid cases, for airway evaluation? Over to you, sir.
Thank you so much for your compliments, sir. And both the questions are very, very important. And this is actually a controversial issue because if you look for the normal values, as I mentioned in my session also, the normal value is here TSH level of 4.5 is acceptable. But we need to consider the, because it will take some time for the TSH to respond. And that's why sometimes looking for the free T3, T4 level is equally important. So what we need to have seen is, we have to look for not only the biochemical parameters, but we also have to look for the clinical symptomatology in these patients. And that's why we are emphasizing on the clinical manifestation. 4.5 TSH level is not just an acceptable limit. It is for medical management. But if you talk about the perioperative period, and if you look for the evidence, the literature has accepted that the overt hypothyroidism with TSH levels going as high as 8 to 9 is acceptable for surgical procedures in case if the patient remains clinically asymptomatic. So this is one of the important aspects, and there is sufficient evidence for saying so that if the patient is clinically asymptomatic, we can accept a TSH level up to 8 to 9 as an acceptable modality for perioperative period. But we should remind ourselves that the patient is not a euthyroid. So we should be taking all precautions for these patients and with good documentation. Coming to the second aspect of airway management, if you see the conventional airway management assessment was clinical and X-ray in the form of soft tissue neck epilateral. This was the most conventional one. But if you see the soft tissue neck, it will not pick up many features, right? It will not show that how much is the compression, how much is the internal diameter of the trachea, because it's a lobulated mass and sometimes you are not able to see it. And that's why the modalities which are emerging are three now. One is virtual endoscopy, second is 3D reconstruction, and third sometimes is ultrasonography, which is not actually for assessment, but post-operative management also at times. So when we say these are the emerging features, emerging one, this has not come into routine clinical practice. So I'll share what we do at our center is, because majority of these patients will have CT scan. We are not getting a different CT scan for our purpose because they will be having a CT scan. So we'll just sit with radiologists and look on them. If we find that there is any major abnormality into the thyroid, then we ask them to do a 3D reconstruction in a specific cases, not for all the patients. So I think 3D reconstruction is not a routine for all the patients. Same will be the virtual endoscopy, because creating a virtual endoscopic pictures from CT scale takes around 1 to 2 hours. So it's not so easy. So in a selected group of patients, you can take up these advanced imaging modalities to take care of your airway management. But on the other hand, I will also say that since the fiberoptic scopy or endoscopy is available at most places, and they are static pictures, they are not dynamic pictures. And we have seen many patients on CT, they will appear normal, but when we start looking for the intubation in these patients after inducing of anesthesia or even under awake, we'll see that the trachea is collapsing like anything, and they will collapse very nicely on patients' breathing patterns. So sometimes it's become too difficult, and they may not correlate with the CT finding, whether it's 3D reconstruction or virtual endoscopy. So at times, what we do in these patients which have a larger mass and we have any suspicion, we do insert a fiberoptic scope and look for dynamicity of the airway collapsibility in these patients and take a decision immediately what needs to be done. So I think in selected group of population, we have to look for these advanced imaging, and based on the clinical examination, we can go ahead and do it. But routinely, I will not suggest that we should have 3D reconstruction and virtual endoscopy for all the patients. This is from my side. I think rest of the seniors can add on if I'm missing something.
If I can just add on. In fact, this is a CBCT 3D reconstruction. I got my own imaging done around a week ago, and it is for everybody else. The results were available in less than 5 minutes. And I was also amazed the way the airway reconstruction was done and a 3D imaging. So that is where I know there is no evidence, research papers available as yet. But the way the imaging techniques are evolving, I think this is beautiful. And we anesthesiologists also need to evolve, and possibly with time, another 2, 3, 5 years, research papers will be coming out on CBCT is basically a dental imaging, but up till the sternal notch, it gives us beautiful imaging of the airways. So possibly something for the future, we may be coming out with these images, which can give us within 5 minutes, beautiful reconstruction of the airways. But again, as you said, the collapsibility, that needs to be seen.
And my suggestion would be that as an anesthesiologist, we are not very well tuned for reading the CT film. And if you see any CT report, there will be hardly any finding of airway assessment there. So what we have done is at our center, whenever the patient comes for PAC, we keep the CT film with us and then discuss with the radiologist, and then we assess the airway. So we always ask our radiologists, why don't you add a paragraph of airway assessment if you get a head and neck CT? But to my knowledge, I don't see any CT film in which they have a separate paragraph of something called an airway assessment. They will mention about thyroid, lymph nodes, they will mention about bony structures, lungs and everything, except the tracheal caliber or the something like this. They will hardly notice these things. So I think we should be learning. So whenever I take up these cases, I always get those films and paste it on my X-ray board in my operating room. And I always review it once again, that what actually the problem is. If I face some difficulty, I review them again inside the theater itself and take my decision. So we should be a little more aware of reading the CT films also of our own.
Can I
Sure, sir.
have a question?
Yeah, please.
Yeah. Is ultrasonography is helpful in these cases? What's your experience in airway assessment?
So regarding the ultrasonography, when we talk about the large thyroid mass, because for the ultrasonography, what we are looking for, we usually, the use of ultrasonography in thyroid cases has primarily been used for vocal cord assessment. That's the primary purpose, preoperatively as well as postoperatively, and more commonly is postoperative vocal cord assessment. If you see the non-thyroid status, we are using the ultrasound for tube placement. We are looking for the tracheal deviation. We are looking for the access to surgical access. Now, all those are limited if you have a large thyroid mass. And when we see a large thyroid mass, there will be focus of calcifications in the thyroid mass itself. And when we have calcification, it will be difficult to put a probe on the thyroid and look for the airway structures, which is too deep. So for a large goitrous mass or even a malignant mass, which are usually calcified, it may not be a good modality for airway assessment in these patients. That's why CT remains one of the good options. Having said that, the post-surgical assessment of vocal cords, now we have sufficient literature that ultrasound can be used for the assessment of vocal cord mobility. So that can be used in these patients as a assessment tool after the surgery, before when you are planning for extubation, to look for that whether the nerve injury has happened or not and vocal cords are moving or not. So this has become one of the modality. And even there are a couple of papers where they have found the tracheal collapsibility also. So when they say tube-in-tube structures and post-operatively, when the cuff is deflated, there are, I think, to my knowledge, 2 or 3 papers where they have looked for that if the tracheomalacia is there, they will not see the double barrel shadows, and the patient may not be extubated at this point of time because there is presence of tracheomalacia. So these are the indications of role of ultrasonography in thyroid patients.
Thank you.
Thank you, sir. Thank you, everyone. Thank you very much. We are running out of time. Is there any question? Anyone want to ask any question? Otherwise, we will move to the second part. Okay, thank you. So just
Dr. Sarad.
Yes, Dr. Yes.
Nice to see all of you. Nice to see all of you. Very nice presentation by our respected speaker, Dr. Rakesh Garg sir. Welcome, and our President-elect of ISA National, Dr. Bjsa sir. Welcome to all of you. Bjsa sir and Rakesh Garg sir.
Thank you, Manoj.
so much,
Thank
Dr.
you.
Manoj.
Thank you, Manoj.
Thank you, sir.
Thank you, Dr. Manoj.
Okay.
Thank you very much. Just wanted to inform all the our members that yesterday we lost one of our senior member of Bihar and Jharkhand, Dr. Pradeep Mukherjee. He was the past president of the Jamshedpur Society of Anesthesiologists. Really a sad day for all of us. He was such a humble and genuine person, always smiling. So I just want our president, ex-president of the GSA, Dr. Sasikant sir. Sasikant sir, are you there? Okay, and Dr. Ashok Jadhan sir, can you say something about Dr. Pradeep Mukherjee, because you must be knowing him very well.
Yeah, Dr. Sharad. I knew him very well for quite a long time. And as we are paying our homages and condolences to him, he was very sweet person, very genuine, very frank, forward, very helping, and very soft-spoken person. He was started his career in Tata Motors Hospital, where I am still working, and then he joined Tinplate Hospital. And we also have companionship when he was practicing, and I was also a freelancer anesthetist. And what can I say, that he was a genuine gentleman in all regards. Now he's no more with us, so I really pray God that his soul may rest in peace, and we will remember him always, that not as a just past president of our society, but as a nice human being and very dear and near colleague, all of us. Sharad, I think it is worth remembering him on this day.
Thank you very much, sir. Thank you. So with this, we come to the end of the CME session. But before that, I would like to tell you that Dr. Bhimeshwar sir is with us since the start. Thank you very much, sir. BGSA is really honored. And I would like to request to that, sir, we give the token of appreciation to Dr. Sagar Rai for his brilliant presentation. Dr. Sagar Rai, please accept the certificate of appreciation from Dr. Bhimeshwar Rai, sir,
Thank you so
President-elect. Just a second. Yeah, please accept the certificate. I request Dr. Bhimeshwar sir to give the certificate to Dr. Sagar Rai.
Yeah, Dr. Sagar, this is a certificate of appreciation for you. You have done a wonderful job. Thank you.
sir. Thank you so much.
I also request you, sir, to give the certificate to Dr. Ashok Jadan for moderating the session as examiner. Dr. Jadan, please accept the certificate from sir.
Dr. Ashok Jadan, sir, you have done a wonderful job. The certificate of appreciation is for you.
Thank you, sir. Thank you, sir. Thank you very much. I appreciate it.
Sir, please give the certificate to Ajit Gupta, sir.
Dr. Ajit Gupta, sir, you have
Thank
done
you,
a
sir.
wonderful job. Thank you very much for that. This is a certificate of appreciation for you.
And a special
Okay, sir.
certificate. And a special certificate to Dr. Rakesh Garg for agreeing to present in a very short span of time, only 2 days. He was kind enough to give his time to BGSA, and BGSA is really honored to have him with us. Thank you, Dr. Rakesh, and request you to please accept the certificate from our President-elect, ISN National.
Dr. Rakesh, this is for you. Very wonderfully done this one. Clarity, conviction, everything is there for you. Wonderful, Rakesh. You'll do very well in your life. Thank you very much. Please accept the certificate of appreciation.
Thank you so much.
Thank you, sir. Now I request our President, Dr. Dinesh Kumar Singh, President BGSA. The BGSA President, Dr. Dinesh Kumar Singh, to say few words and give the word of thanks to all the guests, especially Dr. Bhimeshwar and Dr. Rakesh Garg. Dr. Dinesh, sir, please unmute yourself.
So thank you, Sharad. Thank you. I would like to thank our chief guest, Dr. Bhimeshwar sir, ISA National President-elect. And thank you very much, sir. You stayed here from the very beginning till the last. Thank you, sir.
It's my pleasure, sir. It's an honor for me. Thank you very much.
Thank you, sir. And I would like to thank, special thank to our teacher, guide, Dr. Rakesh Garg, sir. You are really very wonderful, sir. And thank you very much, sir, for your you presented the very nice in a very short time, sir. Thank you, Dr. Rakesh Garg, sir.
Thank you so much, sir. Thank you so much for your kind words, sir.
And my sincere thanks to Dr. Ajit Gupta, sir. Sir, please accept my thanks.
Thanks a lot. Thanks a lot, Dr. Dinesh.
Thank you, sir.
Ever smiling.
Yes, sir. Thank you, sir. And last but not the least, our beloved Dr. Ashok Jadan, sir. Thanks very much for being with us and guiding us, teaching us. Always you are with us. Thank you, sir.
Thank you, Dr. DK. Thank you very much. We are always with you.
Okay.
Thank you.
Okay, thanks to everybody. Over to Sharad. Sharad, kindly conclude the session now.
Yes, sir. Thank you, Dr. DK Singh, sir. For
Sarad boss. Can I see
yes,
few words?
Sure.
Please. Yes, Dr. Manoj, please.
Yes, Manoj.
Thank you very much, our President-elect. You have attended first time. We are great pleasure to see as a chief guest of the Bihar Society of
It's an honor, Manoj. It's an honor for me.
So
thank you.
I request you, sir. I request you. This is your tenure. So kindly uplift our BJSA society from this level. So we can expect we will reach in the top of the state branch or and city branch level. So kindly appreciate our work, sir. Thank you, sir. And I also thanks to Dr. Rakesh Garg, sir. We are very thankful to you as a moderator, and Dr. Ashok Jadon, sir, Dr. Ajit Gupta, sir, our president, Dr. D.K. Singh, our secretary, Dr. Sarad. We have you are done very wonderful job for the society. Thank you. Thanks for our delegates and PG students for attending this CME session. Thank you. Over to Sarad, boss.
Thank you, Dr. Manoj. Any member want to say anything? Otherwise, we will close it.
Sir, I would like to thanks a special thanks and congratulations to our student, Dr.
Yes, sir.
Dr. Suraj. Hello, Dr. Suraj.
Dr. Suraj Bhan. Hello. Whose voice?
I am Dr. D.K.
Sir, आपकी आवाज नहीं आ रही. कौन बोल रहे?
D.K. Singh. D.K. Singh.
Suraj.
Yes, sir. Please go ahead, sir.
Suraj को special thanks देना था. He presented very nice.
Sagar.
Dr. Suraj.
Sagar, sir. Sagar.
Sagar Rai.
Okay.
Sagar
Thank
Rai.
you, sir. Thank you very much, sir. Thank you so much, sir. The encouragement.
Okay. Oh, okay, sir.
Thank you, sir. Okay. So कोई कुछ कहना चाहता है तो जरूर से 2 मिनट है हमारे पास. Then we will close. Any member want to say anything?
नहीं, हम कह रहे हैं सर कि भीमेश्वर सर से थोड़ा पूछिए कि बिहार झारखंड के लिए सर हम लोग का जो है कैसे और लेवल ऊपर है आए.
Okay, so Dr. Bhimeshwar. Hello, Dr. Bhimeshwar, sir.
Yeah, tell me.
Okay, sir. As you know, sir, this
Manoj, whatever you ask for Bihar and Jharkhand, it will be done during my tenure. Don't worry.
That's great.
I am there with you.
Thank you,
Thank
sir.
you very much, sir.
Thank you very much.
Yeah, that's great for all support.
Thank you, sir.
Definitely.
So with this, we come to the end of today's session. I would like to thank each and every one of you for spending your evening with us. And we learned a lot from all the judges as well as Sagar Rai, and especially from Dr. Rakesh Garg. Wonderful lecture, sir. And we have recorded your lecture. Sometime when I will be free, I will listen it carefully. So thank you, sir. Thank you, Dr. Bhimeshwar and Dr. Dinesh. Thank you very much, Dr. Manoj, Dr. Nag, Dr. Koshi Varghese, Dr. Srividya, Dr. I can see few names, Dr. Ravinder, Dr. Abhay, everyone. Thank you very much for your time and patiently hearing.
And Dr. Sharad.
And Dr. Nishant. Dr. Nishant, are you there?
Nishant.
Yeah, he was with us.
Yes, sir.
Dr. Sharad.
Dr. Nishant, I want to say especially thanks to you. You are wonderful, yaar. You just gave me the idea कि किसको बुलाना. You are awesome. I really want to thank publicly that you always with the BGSA, and we will do best for you also. We want to see you at the national level. You are doing wonderful job, Nishant. Thank you very much.
Sharad.
Thank you, sir. Thank you so much. And
You are appreciating everyone. On the behalf of everyone, I must appreciate you. You are doing a wonderful job, and you have a wonderful team like Nishant and other people, Dr. Manoj, and really great efforts and pain you are taking to upliftment of our society. So gratitude for you as well.
Thank you. And long live ISA.
Thank you. Long live ISA, long live Bihar Jharkhand Society of Anesthesiologists.
Yes, long live ISA. So good night.
Good night. Thank you very much.
Thank you very much.
Good night.
YouTube link be available. Anyone want to see? You can hear on the YouTube link. I can share it. It is on the Facebook also. It is available on the Facebook of the BGSA. Thank you very much. Thank you.
See you again. Thank you, Nishant. Thank you.
Good night, everybody. Good night, everybody.
Good night, everyone, sir. Thank you very much for the opportunity.
Thank you, sir. Thank you.
Good night, sir.
Good night.